really good session, I hope. Very much built off the back of the most recent announcements to do with the vaccine, which of course the Pfizer-BioNTech vaccine, it's been described as pinpricks of light at the end of a tunnel. However, something that has been concerning everybody, I know, is that we still don't know how long that tunnel is and what it's going to take to get that train safely into the station. Meanwhile, tragically, we are still seeing mounting numbers of deaths in the UK. We've now exceeded 50,000, and the worst of that second wave is still ahead of us. One argument, and I think it's a really important argument to make, is that we really cannot take the eye off the ball of having some kind of government exit strategy. The vaccine is no silver bullet, and we are proposing that the government should be considering alternatives to this boom and bust strategy that they seem to be undergoing at the moment. The most recent announcement, of course, being that if we are allowed to have Christmas, we're going to have 5 days of lockdown for every day of Christmas that we have. And there is an alternative, and it's called the COVID Secure UK Plan. And in brief, it proposes moving our front line in the fight against the virus away from schools, workplaces and communities, and refocusing our efforts on catching new cases at the UK entry ports, such as airports, ports and international train stations. And so that would allow the economy to fire on all cylinders while protecting both people's lives and livelihoods. And it sounds great, and there's steps to get there, but it is an alternative plan. So to take us through some of this and also some of the wider issues, we've got three eminent panelists. I'm delighted to have them with us. Thank you so much for joining us. We've got Professor Martin McKee, CBE. He's part of the Independent Sage Advisory Group, but is also Professor of European Public Health at the London School of Hygiene and Tropical Medicine. So welcome, Martin. We've got Professor Devi Sridhar, who is part of the Scottish Government's COVID-19 Advisory Group and Professor and Chair of the Global Public Health at the University of Edinburgh. So welcome, Devi. Thank you so much for joining us. And last but not least, Professor Stephen Reicher is a Professor of Psychology at the University of St Andrews, a Fellow of the Royal Society of Edinburgh, and a member of the Behavioural Science Advisory Group in SAGE. So we have a huge amount of knowledge in this room today. And the way that we will run this is, again, and I would like to invite Professor Martin McKee to perhaps tell us a bit more about this vaccine. Martin, is it going to solve all of our problems?
Well, we've really got to celebrate it because it is remarkable news. If you think about it, it normally takes about 10 years to get a vaccine to market. And the companies involved and the researchers involved have done this in a remarkably short space of time. And importantly, they've done it without cutting corners. They've been able to move through the process of doing the investigation, doing the studies that are needed, while still adhering to all of the elements of good research practice. So that's really good news. However, there are a number of questions that are still outstanding, and some of them are inevitable because of the passage of time. This is a new disease, and we haven't had the time to know how long the immunity will last for. There are a lot of good signs there. So the vaccines that have reported in the phase 3 trials, the Moderna and the Pfizer one, clearly are providing protection. And although we know that the antibody levels do wane in COVID, we also know that the antibodies are not the only marker of protection. So we have T-cell immunity. The immune system is a very complex system. And if we look at the experience with SARS, we can see that people who were infected 17 years ago may still have a degree of immunity to that because of the persistence of memory in the T cells. So that is good news. We also have good news in the Pfizer vaccine in that they have reported a 94% protection in people who are over 65. They say they've got a group of people who are mixed in terms of their ethnicity, and that's good news too. But of course, with both of these, we are still waiting for the peer-reviewed papers with all of the details. We've only had press releases, but there's no reason to believe that the fundamental results in the press releases will be different. We just need to have that more nuanced information when we get the papers. One of the things that we don't know is whether the vaccines will be what we call sterilizing, which means that they will prevent people becoming infected, or whether they will just be neutralizing. Now, neutralizing is hugely important, because if neutralizing immunity will prevent people from getting severe infection and complications and dying, that's what we want to achieve. It would be better if we were to get sterilizing immunity so they wouldn't get infected and pass it on at all. However, the animal studies that have been done with the vaccine suggest it's primarily the neutralizing immunity, and everything we know about other forms of vaccines suggests that you probably need to use inhaled vaccines like flu vaccines in children to get the sterilizing immunity. On the other hand, of course, people who have been vaccinated and are then exposed a second time, they may well have sterilizing immunity. So again, many questions we don't know. But good news, I think that really has to be stressed, and we can rely, I think, on the very rigorous work that's been done. Then the next step is, it's not vaccines that save lives, it's vaccinating people. And that's really the challenge that we face. This is a huge logistic operation. We've done quite a lot of work in 2 reports for different parts of the European Commission we've published in the last 2 years, looking at vaccination systems, the systems approach and the systems science, drawing on the work that Stephen and others do on behavioral science and working with systems analysts and so on to think about what are the elements that we need. The good news is that in the UK, many of the elements are already in place, but the concern is that there are still quite a few gaps. So we need a system for gathering and synthesizing evidence, and we have that. We have a very strong research community in the UK. We need a system for funding and procurement. The money has been made available. There are orders for vaccines. By my count, I reckon 355 million doses, which is the equivalent enough to vaccinate 177 million people, more than 2.5 times the British population, have been ordered. And, of course, the government ordered more than they would need for the population, because you don't know which one is going to come up trumps. The Canadian government have ordered even more. They've ordered 5 times their population. But if everything works out, then we should have enough vaccine once they are manufactured and produced and so on. We need legislation to decide who can vaccinate. And in October, the Human Medicines regulations were amended, and they were amended to facilitate the approval of the vaccine by the MHRA. Good. They also made it possible for the number of people who can administer the vaccines to be expanded to medical students, nursing students, and in an article in the Daily Telegraph the other day, it was mentioned also St. John's Ambulance and others. So that is helpful. Questions about training. A news item I've just seen came out in the last 4 hours suggests that people will be trained with a 2-hour online video. We need to be sure that that works. So there are some questions there, particularly given the way in which it's not just the technical process of injecting and putting a needle into somebody's arm, but it's dealing with their anxieties, dealing with their concerns, dealing with their worries. So I think some questions are outstanding there. I think where I'm perhaps most concerned is that you need some sort of a population register or some information about who is the target population. You need that for a number of reasons, because you really need to identify who is not taking up the vaccine. You need to have a denominator population, and particularly you want to know where there are groups in the population who, for reasons of education or income or where they live or ethnicity or something like that, are not being included. And unless you know the characteristics of the target population, you will not know that. You need a system of prioritizing. Now, in September, the JCVI put out a set of proposals, but they are only proposals. And again, somebody else may know how far that has gone, whether they've been adopted. They start off with people in care homes and the workers who care for them, and then they move to the over 80s and NHS and social care workers, and then progressively move down the age bands. At the age of 65, they bring in high-risk people under 65 as well. So that is good. We need a system for monitoring uptake, and I'm not sure that we have that in place yet. That depends on having a register. So for example, if we're vaccinating people in care homes and in the healthcare workforce, we need to know who is in the workforce. And unfortunately, we do know that the records are not always up to date. We know that there are gaps, and we know that this is often fragmented. There is, for the NHS, an electronic record for every individual, but we also know that there have been some problems with that. But then we get onto some of the key issues. And I think here we need to keep monitoring, and Steve will talk about this more, public attitudes, miscommunication. We need to understand whether people are uninformed about the benefits of vaccination or whether they are misinformed. And that, which is something that the DCMS committee has written about extensively in an excellent report a few years ago, Disinformation and Fake News. Highly recommend reading that, because the evidence that we provide, the way that we address that the people who are uninformed or misinformed is quite different. And there is a real danger. We can tell people the evidence if they're uninformed, just training and education. But if people firmly believe something which is wrong, then giving them that information can easily backfire. And again, Steve, I'm sure we'll pick up on that, but there is a large literature on how you can actually make things worse. But then we get onto the logistics. And I think that's the area that has been, for us, the most difficult to understand. We are told that there will be, I think, 1,500 vaccination centres. That would be the equivalent of 6 or 7 in every lower tier local authority in England. That may provide a degree of geographical dispersion that would make it easy for people to get to. But I think the practicalities of doing all of that are enormous. This is a massive exercise. You know, we talk about things being like the D-Day landings and so on, but this is maybe not on that scale, but close to it. And I think it's been very difficult for those of us outside government to try to find exactly how that is going to be done. And unfortunately, the experience with some of the other things like testing and tracing gives us some cause for concern, because there have been problems. And we need a system, a really rigorous system of evaluation to identify where everything's going. I think on the logistics, it would be great if ministers could provide basically a flip chart with a diagram of all of the elements and arrows linking them for the flows of information, the flows of resources. I think we need that strategic plan somewhere that's visible so that everyone everywhere knows what their role is. And this was not the case, unfortunately, with the testing or the tracing system. We had fragmentation, people didn't know who to talk to. So I'll stop at that point, because I think the key message is it's great news that we are where we are, but this is really only, to paraphrase someone else, the end of the beginning.
Well, thank you so much, Martin. I think that's really put it all into its context. I can see questions are flowing in, which is wonderful. If you put up your hands, or if you put the question in the chat, we'll make sure everyone gets called. And so we'll try and leave as much time at the end to be able to answer all your questions. If we aren't able to, we'll collate them and see if we can ask the panelists if they wouldn't mind giving comments on this if it's not something they've covered elsewhere. But now can we move to Professor Devi Sridhar. Thank you so much for joining us, Devi.
Hi, thanks, Leila. I'm excited to be here. Martin's given a great exposition of where we are with the vaccine, some of the challenges, some of the opportunities. I don't want to repeat anything that he said. I'm actually just going to make 6 points, and I'll try to do it as briefly as possible. So the first is, living with this virus means living with restrictions. And that's because of the hospitalization rate of the virus. It's why we're seeing reactive lockdowns throughout Europe, because once you're in a position where health services are being strained, governments are forced to protect those health services so they don't collapse, not just for COVID patients, but for heart attacks, if you're an injury on the motorway. And so this is what really gets us with this virus. And this is, hospitalization rates are high, even in younger people, people in their 30s and 40s. They may not need ICU beds, but they need oxygen, they need care, they need support. And so this, I think this kind of gets to the core that the countries that are saying we're going to live with this, we're going to be living with restrictions for the foreseeable future. And that leads to the second point, which is this is much worse for the economy. It's like a slow strangulation. I could kind of see this already in August and July when we were opening up, when we had these painful debates on 1 meter versus 2 meter in restaurants, and businesses were completely changing, fitness studios, how they operated. And you're thinking, actually, these businesses aren't going to be able to run at 1 or 2 meters because we know the virus circulates in the air, and these are high risk settings. And the only way to open hospitality and nightclubs and live music and conferences and big sports events is if you really have no virus circulating, and you just have small pockets of it. So that comes to their point. Well, what can you do about it, right? So we know we have a virus, it causes hospitalization rates. Are we fated to be in these lockdown release cycles? And that point is actually there are countries which are not in lockdown release cycles. And what are they doing? And what are the countries that are winning? So what does winning at COVID mean? So for me, it means that you keep your COVID deaths low, you keep your health services running, you keep your unemployment low and your economy running, and you also keep schools open and some kind of social normality. We are social beings. We want to interact with other people, and we want to hug them. We want to be close to them, and we shouldn't in any way underplay that actually humans need that. People do die of loneliness. So the countries that are winning are in East Asia, because they're managing to do that. Increasingly in the Pacific, Australia, New Zealand, but also in Europe. The two countries I don't think have gotten enough attention are Norway and Finland. So what are these countries doing? So they've really all done three things. It's quite simple, and this fits into the COVID secure plan that Leila presented at the start. So the first is having very good guidance to the public about how you avoid getting this virus and why it's important to move on it. So what does this mean? It means, avoid crowded settings. You don't want to get it at any age. We don't want to somehow try to get young people infected to build up herd immunity, because we know that's so far off. This is how you can avoid it. Avoid unventilated, indoor, crowded settings for a period of time till we get prevalence really low and those settings become safe because there's no virus circulating. The second thing they've done, so they never had these debates about the young versus the old, about do tests work? Is it so bad? Is it like flu? Like they just went to how do we deal with the problem? Not like, is it a problem? Which I think the UK has been a bit stuck in. The second thing they've done is really good test, trace, isolate. And I want to focus here on the testing and the isolation part, because I think the tracing is actually decent in the UK. So the testing means results back within 24 hours, because your tracing teams have to get moving. And if you have delays of a week, in some ways it's too late because the chains of infection move too quickly, or whether you're doing forward tracing or backwards tracing. And the next part on isolation is the whole point of testing and tracing is to get to isolation, because if someone's test positive and then goes and lives their life because they think I'm positive anyways, they're going to infect others. So isolation is an act of goodwill. It's what you're doing to help others. So people need to be compensated. So how are they compensated? So New York City has over 95% isolation rates. I've joined a couple of their COVID advisory group meetings, which has been fascinating of how do they do that? Because they're not locking people in their homes. Three things. You pay people to stay home. It is your job. You're paid a lot, not a lot in terms of kind of, 12 billion that we spend on test and trace, but a good amount. The second thing you do is you offer practical support. So they have people call you, they have people go by in person and stand at the door at a distance and say, are you doing okay? They offer care packages of essential foods, groceries. So they really kind of helps people to say, we're going to help you through this 14 days. And the third thing is they've offered hotel rooms, which has helped their domestic tourism. So people can isolate outside of their homes and break those household chains or flat kind of chains of transmission. So then the third thing is the border measures, and this is where Europe keeps falling down. So Norway and Finland over the summer did not encourage their populations to go abroad on holidays. They said, stay home, stay domestic, and they have very strict border checks. No country has sustainably suppressed COVID-19 without strict border measures. And the reason is you just go into lockdown, you crush your numbers, and then you have imported chains of infection and it starts up again. And the UK in some ways in a halfway house, because we have passenger traffic collapsing, we see aviation struggling. So we're taking the costs, but we're not having the benefits because we're not having the checks on actually the people coming through. And something we've learned, for example, from Iceland is they had 2 people come in, test positive at the airport, were supposed to isolate, didn't, decide to continue their holiday, infected 100 people within a few days and set off a whole second wave. And they're now trying to get on top of it. So it shows you how important that kind of catching of people at airports and then supporting the isolation. Okay, fourth point now. So what can we do at this point with the COVID secure plan? So I think different nations have tried it. So Scotland attempted this in the summer. We got down to really negligible levels. And what became clear, and I guess sitting in Edinburgh, is we need an all-island approach. We need also England and Wales, and we also need Northern Ireland and Ireland, almost a 2-island approach. Ireland said early on it would not go for elimination or even kind of a COVID secure plan, because they couldn't get Northern Ireland and they have such a long land border. Gabriel Scally has spoken a lot about this. So they had to cooperate. And we're seeing the same thing now in Europe, where actually Germany is trying to drive down numbers, but it has borders with 9 other countries. So it has to be speaking to all those countries. Otherwise, there's no point putting in place restrictions if people are constantly going back and forth and they say, actually, I'm going to go abroad, I'm going to go across the border to the pubs and the restaurants that are open and not the ones that are here. So we need cooperation around a shared strategy. And that's been really challenging for Europe. So last thing I would like to say, and then I'll stop, is about a vaccine. Similar to what Martin said, a vaccine is not going to be a silver bullet. It's not going to be that we suddenly have it and the problem is gone, especially with these vaccines, because there's so many unknowns. They haven't been trialed in children. We don't know if they stop transmission. We don't know how long immunity lasts. It's fantastic. We were going to have, I think, at least 3 or 4, but they're part of a strategy. And just to kind of end with, different countries are going to use it in a different way. So New York City, what they're talking about is mass vaccination of those who are essential workers and are most likely to spread the virus, especially if it stops them being infectious. So this means going after, healthcare workers, but also security guards, taxi drivers, grocery store workers. Basically, your chains of infection are super spreading occupations. So you're really trying to suppress the virus and get the numbers low, and using your vaccine almost as like a strategy to help you break those chains. The second way I've seen this being used is actually Australia. I joined kind of the Australian Public Health Conference, and the Chief Health Officer of Victoria State, which has just kind of crushed the curve. We had similar numbers to Victoria in July, but they stayed in lockdown longer, did massive testing, and they basically now back to normal. They're having their large sports events and gatherings up to 50 and 100 people. And they said, well, they've hard won those gains. They're not going to lose that with a vaccine. They're going to use a vaccine to do ring vaccination around flare-ups. So kind of like how we've used the Ebola vaccine in the DRC, where you have flare-ups and you immunize the contacts and healthcare workers to stop the flare-up and continue your elimination strategy. And South Korea has said something similar. They said, look, they're not even looking to use a vaccine until the second half of 2021. They want to wait and watch what happens in other parts of the world, because they have a strategy. They've got their mass testing. They've got kind of a sustainable way of going and keeping their economy somewhat decently. They're struggling. Every country is struggling, but they're finding a way, and they don't want to rush. And especially given that a lot of the doses have anyway been purchased by European and North American countries. And then finally, I think what we're talking about in the UK is more like a flu mitigation strategy, which is immunizing those who are most at risk of dying. So you're thinking those who are over 80, those who are in care homes, which is appropriate, because right now, obviously, we want to stop deaths. But it doesn't mean we can lift restrictions, because it doesn't get around your hospitalization rate, to come back to the beginning of where I started. And so it does mean we will find a way through this, but probably a faster way through it than a vaccine is going to be through mass testing and isolation. The mass testing only works if you've got good uptake and compliance and good isolation. And Slovakia is very fascinating to watch, because to stay out of lockdown as their numbers went up, they bought 3.5 million rapid antigen tests from South Korea that give results within 15 minutes. They tested their entire adult and teenage population practically in a weekend, isolated about the 1% who had the virus. And how they did that was telling people everyone is required to isolate unless you test negative. So you create an incentive for people to get tested, rather than an incentive for people to say, actually, I don't want to get tested in case I test positive and have to isolate. And I know uptake has been an issue in Liverpool. And I think that's something to look at, which is that acceptable to people to say, actually, you have to stay home, but if you test negative, you can be released. The incubation period is an issue. We know also that these tests don't pick up asymptomatics or low viral loads. So they're redoing the whole thing again a few days later. But then the question becomes, okay, once they found all the cases, once they've reduced them, how do you protect it? So they're putting in place very strong border checks to make sure they don't re-import it. And border checks means testing. Doesn't mean stealing yourself off from the world. It could mean testing at the airports, testing when people arrive, and 5 days later, you won't catch all the cases, but you'll catch, hopefully, the vast majority. So I'll stop there. Thank you.
Thank you so much, Devi. Lots of food for thought there. So next we have Stephen Reicher, who is going to tell us how to influence everyone to do all these things that we need them to do, hopefully. Stephen.
Yes, and I'll also tell you how to cure cancer and how to play the flute. I'll do my best. Compliance is obviously critical. Behavior is critical. You can have all the restrictions in the world that you like, but if people don't obey them, then they're of little use. And equally, as Martin said, vaccines solve nothing. It's people getting vaccinated that solves something. So we have the question of, will people get vaccinated or not? And we know recent surveys suggest about 70% of the population say they are very or somewhat likely to take the vaccine. Actually, the figure I saw was 71.48, if you like precision. Now, first of all, I want to make, I think, a key point, and it's already been alluded to, which is we need to distinguish very clearly between what are called anti-vaxxers, those people who on principle are against vaccines and wouldn't take them come what may, and what we call the vaccine hesitant. In other words, people who have questions. And I think we've got to be very careful not to problematize or pathologize the vaccine hesitant. What they're doing is perfectly sensible. In fact, you would be foolish to take a vaccine unless you were confident it was safe. You shouldn't put something into your body unless you see that the processes are right. And if we lump the vaccine hesitant and the anti-vaxxers together, the danger is we alienate them and push them into the hands of the anti-vaxxers. We need to treat them as perfectly reasonable, and we need to engage with them and inform them. So that's the first point. But I want to start off more generally by talking about compliance and where we are with compliance, and deal with what I think might be three misconceptions. The first is that when it comes to levels of compliance, often we misestimate them because actually what we see in the media are stories of non-compliance, because a spectacular story of a house party is a far more interesting front page than a rather dull story of people sitting quietly at home doing the right thing. And one of the things that's rather surprised me during this pandemic is there hasn't been more of a dialogue with the media, with the editors, to make clear the importance of balanced reporting. Because if you give too much reporting of violations, it begins to tell people that other people are violating, it sets a norm, and it can actually undermine levels of violation. So if you look at the figures, it suggests that in many areas, actually, compliance is very good. So if you look at mask wearing, if you look at distancing, physical distancing behaviors, they're up about 80 or 90%. And the good thing is these aren't just self-reports. It's not just what people say they would do, because of course people would say they're doing the right thing. It also comes from systematic observation. I don't know whether you noticed, but there are people who sit around in the London stations and count how many of you are wearing masks or not wearing masks. So it's pretty good data. The one exception, and Devi has already alluded to this, is in terms of self-isolation. That, depending on the figures, is, I don't think it's too strong to say, is catastrophically low. It's as low as about 10% of people are fully complying with self-isolation. And the discrepancy between that figure and the other figures suggests that it's not a matter of motivation, it's a matter of practicality. Self-isolating is a difficult thing to do if you think you'll lose your job or you'll lose money. If you live in a multi-occupancy house where you haven't got your own toilet, you haven't got your own bathroom, you haven't got your own kitchen. It's difficult if you've got caring responsibilities in the house, outside the house. It's difficult for emotional reasons. And as I say, what that suggests is that the issue isn't that we have people of ill will who don't want to do things. We have people of goodwill finding things very difficult to do. So instead of castigating people and blaming people, the key issue is to support them. We should actually stop using the term self-isolation. I think it's an unhelpful term. We should talk about supported isolation, because isolation is only something you can achieve with the support of others. It's only something you can achieve together. And if you load it on the individual, you're going to have real problems. And again, I think we can be much more creative. And Devi gave the example of New York City in the multiple ways in which we can support people. These are people who are doing something for their community. So their community in return should do something for them. And not only is this a matter of what government does, I think we should enlist those many thousands of mutual aid groups up and down the country to support people. We could also actually invoke and use the private sector. You know, one of the things I always say is if you could get the gaming industry to give free games to people who self-isolate, well, I've got a 16-year-old. My problem at that point would not be to stop him to go out, it would be ever to get him to go out. So I think we could be much more creative in that regard. The second misconception is, what are the violations? And again, it comes back to the media issue, I think, that the focus is on the egregious violations, you know, the raves, the mass house parties. That's what people talk about. But the problem is that leads people to begin to think it's not me, it's them. A while ago, I was at a meeting of the Scottish Police. They'd been to 440 house gatherings, been called to 440 these gatherings in 1 week. Only 13, less than 2%, were of over 15 people. The rest were people slightly bending the rules. And when the police knocked on their door and asked, why are you doing it? Their response was, well, why are you knocking on our door? It's not us. We're not having parties. So the danger is that if you misrepresent what the violations are, it leads people to think it's not me, that the messaging isn't self-relevant, and it doesn't really matter that they're having little violations, little bendings of the rules. So again, I think it's unhelpful to talk in terms of people flouting the rules or brazen violations. This is perfectly decent people accumulating small violations to adapt a catchphrase. Every little hurts. And again, I think we need to refocus where we see the problem and talk to people in a less, if you like, headmasterly way, wagging your finger and telling people off. And the third thing is why. Why are we beginning to see some of these violations? As I say, overall things are pretty good, but we're beginning to see problems, no doubt. And we've heard a lot of talk about fatigue, about pandemic fatigue. We heard about it before the first lockdown, and actually what we found was that was wrong. People showed remarkable resilience. There was a lovely study from King's College London, Bobby Duffy's group, showing that over 90% of people were complying, but over 44% of those were suffering, but they were still going along with things. People showed real resilience. And what's changed isn't within people. It's not that people have no longer have that resilience. I think what has changed is the relationship between the public and the government. And two factors in particular are important. Trust. Big international studies, 67 nations, 46,000 people, shows how important trust is in terms of people adhering. And sadly, in the UK, trust in government has fallen catastrophically from 75% in April to it's bouncing around 30% now. It's different in the devolved nations, incidentally. In Scotland, it's about 71%. So trust is a critical issue. And a second issue is effectiveness. You see, what we've seen is people, as I say, can be resilient. They will take the pain if they think there's a gain. But people aren't stupid. They're not going to go through restrictions if they think there's no point to them. And if you look at the debates and the controversies there were, say, around the north of England tiered system, the argument wasn't against restrictions per se. It was against restrictions which are hard to adhere to because there isn't support, and restrictions which people think are ineffective. And paradoxically, and the medical literature supports this, paradoxically, sometimes people are willing to put up with more severe courses of action if they think they're more effective. People will often take longer courses of drugs rather than shorter courses of drugs because they think the longer ones will actually work. So we need to give people a sense of effectiveness. Now, in a sense, trust and effectiveness go together. Because one of the paradoxes, one of the difficulties of this pandemic is you only see the effects of your actions long after, 2 or 3 weeks after. So we ask people, say, to go into restrictions, and they have to trust us that those are going to bring down the infection rate in time. But I think there's another issue that is absolutely critical. People have got to believe that once the restrictions are lifted, it's not that infections will simply spike again and they'll have wasted their time, that we will yo-yo in and out, what Martin called boom and bust, between restrictions, relaxations for a short time, back into restrictions and so on. And that again is why I think the important issue about restrictions is not only that they're seen as effective in and of themselves in bringing the infection down, but they allow us time to do things which make sure it doesn't spike again. And we've heard some of those things today. And in many ways, that's the rationale for the COVID secure plan. It's not only that a clear plan is important to bring the infections down, it's also that that clear plan gives people a sense of effectiveness, which means that they will adhere to those measures that will bring infections down. So we've heard about two elements of that. One critical one is the test and trace system. The second is the issue of borders. But a third, I think, is the relationship between the government and the public. If I was talking about a reset, and we've heard a lot of talk about reset in recent days, I think restoring the bond of public trust. Restoring the contract between government and the public is really important. So how do you do that? And I think what we've seen a lot of the time in recent months have been sometimes government and commentators blaming the public, treating the public as other, saying that it's their fault for doing things. I think it's important that we shift and stop seeing the public as the problem and start seeing them as a solution, to move away from a form of paternalism which wags your finger at the public to a partnership where you work with the public and respect the public. And that means a number of things. It means openness. That openness is going to be absolutely critical in terms of the vaccine and people taking the vaccine. And it's very important not to overstate things. And that comes to the second point, which is a certain level of humility. Not overstating the case. If you say something is perfect, nothing's perfect, it won't be perfect, there will be problems with the vaccine and people will become disillusioned. So as we know, the thing that destroys all empires is hubris. Hubris, when it comes to a pandemic, is equally destructive of any trust. So I think that's got to be dealt with. And the third thing is support. One of the fundamental lessons of social influence is telling others what to do is rarely effective. What is far more effective is to act in ways that show that you are on their side, and then people are more likely to reciprocate. So if we give people the support they need, whether it be to self-isolate or anything else, and we demonstrate in practice we are on the side of the public, then the public is much more likely to take its responsibilities seriously. So in many ways, that reset, as I say, is a pivot from a paternalistic notion of blame to a partnership in which we support the public to do the right thing and we ask them to adhere to the measures which are necessary. And as I say, a shift from seeing the public as the problem to seeing the public as a solution. So